Good morning. I'm Dr. Sid Ganguly. I'm a professor of medicine at the University of Kansas Health System in Kansas City, Kansas. I'm also the deputy director of the Division of Hematologic Malignancies and Cellular Therapeutics. And above all, I'm a transplanter. Happy to be here in Orlando during ASH 2019. And I have a presentation on Monday in the acute myeloid leukemia section. This is basically talking about the role of quizartinib in the post and pre-transplant setting. So quizartinib is a potent FLT3 inhibitor. We all understand that FLT3-ITD mutated patients with relapsed refractory acute myeloid leukemia have a poor prognosis and very limited options for the treatment. Quizartinib is a very potent oral and very selective FLT3 inhibitor. Last year in ASH 2018, Dr. Jorge Cortes presented a global phase 3 trial called QuANTUM-R, where quizartinib was compared with salvage chemotherapy in patients with FLT3 positive relapsed refractory acute myeloid leukemia. And it showed that there was significant survival advantage with quizartinib compared to the salvage chemotherapy arm. Now, I'm going to present tomorrow, Monday, a post hoc analysis of the clinical characteristics and outcome of the patient from the same trial that underwent subsequent allogeneic stem cell transplantation. So, if you remember, the overall survival for patients that received the quizartinib was around 6.7 months, but the patients that underwent allogeneic transplantation, the survival rose almost up to 12 months. The interesting part is there are more patients that achieved complete remission, composite complete remission in the quizartinib arm, and the duration of the CR was also longer using the quizartinib compared to the salvage chemotherapy arm. And what that did, that led the transplant physician an opportunity to find a donor, take the patients to a transplantation. And that's exactly what is reflected in my abstract. That shows that the transplantation rate is much higher in the Q arm compared to the salvage chemotherapy arm. However, whoever got the transplant reaped the benefit. So it does not matter whether you got the Q or the salvage chemotherapy, as long as they got the transplant, they survived longer. But more patients went to the transplant having had the Q because they had longer duration of CR and more CR. So now, after achieving the CR, if the patient goes to the transplantation, patients were also allowed to continue quizartinib in the Q arm post-transplantation. So around 48 patients actually continued quizartinib after allotransplant. The salvage chemotherapy patients were not allowed to continue the quizartinib. But taking the quizartinib, the survival even increased. So after the transplant, the median survival was around 12.2 months. Now, if a patient received quizartinib, then went into transplant with complete remission, and then started quizartinib, now we are seeing a survival of 25 months. This is almost unheard of in patients with FLT3-ITD mutated relapsed refractory acute myeloid leukemia. So a paradigm seems to be emerging that if a patient has dismal prognosis, relapsed refractory FLT3-ITD AML, can we give them a strong potent FLT3 inhibitor, get them to a CR, take them to the transplant without any delay, and then post-transplantation put them on a Q maintenance. And that is a question that needs to be addressed by a prospective trial. This particular oral abstract of mine is a post hoc analysis. So we do not have a granular data of all those transplant patients. So we're trying to reach out to CIBMTR, which is an organization that actually keeps all the post-transplant data. And hopefully, in collaboration with CIBMTR, we'll have more granular data. And who are those patients who survive longer? There are some patients who actually live longer than 2 years. And maybe I'll come back next year with a next abstract showing who are those patients that actually survived FLT3-ITD positive AML after receiving quizartinib.